Hello guys, in this video, I'm gonna discuss about pathophysiology of type 2 diabetes mellitus. Before proceeding further, I'd like to refresh your memory with physiology of insulin first. So, in our body, there is a gland called pancreas, and which can perform both endocrine and exocrine function. The pancreas contains about 1 million islets scattered throughout the exocrine parenchyma. When we look into an islet, here it is figure B. The core of islets consists of beta cells that synthesize and produce insulin, and which is surrounded by a cortex of endocrine cells that produce other hormones, including glucagon from alpha cell, somatostatin from delta cells, pancreatic polypeptide from F cells. Okay, so when we magnify in a beta cell, here it is figure C. So what happened after a meal? After a meal, our blood glucose level is high, and glucose enter into beta cells through glucose transporter 1 or 2, which is insulin independent, and then glucose enter into glycolysis and subsequent oxidative phosphorylation in mitochondria with resultant ATP production. ATP acts to close the potassium channel and leads to membrane depolarization and rise in membrane potential, which result in calcium influx due to opening of the voltage-gated calcium channel, and the rise in intracellular calcium causes insulin secretory vesicles to fuse with cell membrane and finally leading to insulin secretion. So, other stimuli such as glucagon-like peptide 1 act on the G protein carpet receptor to raise cyclic AMP and amplifying the insulin secretion. So, when insulin is released, what happens next? Insulin binds to the insulin receptor, and here it is, and then triggering a complex signaling cascade ultimately leads to translocation on GLUT4 from GLUT4 storage vesicles to cell membrane and allowing cells to take up glucose into the cells. So in that way, insulin promotes uptake of glucose into muscle and adipose tissue and function to lower the blood glucose level. So after refreshing our memory with physiology of insulin, I'll continue with pathogenesis of type 2 diabetes mellitus. So we have already known that there are two important mechanisms in pathogenesis of type 2 diabetes mellitus, which are insulin resistance and beta cell dysfunction or defective insulin secretion. Approximately 40% of overall type 2 diabetes mellitus risk is determined by genetic factors, with the rest due to environmental factors. And both insulin resistance and beta cell dysfunction have combination of genetic and environmental determinants. So let's have a look into risk factor for causing insulin resistance. There are abnormalities in post-receptor intracellular signaling pathways downstream from the insulin receptor. So here it is. Insulin cannot perform its function due to insulin resistance, and then glucose cannot enter into the cells and finally leading to increased blood glucose level. So then the next thing is the second important risk factor causing insulin resistance is obesity. So in a obese patient, the intra-abdominal central adipose tissue. The intra-abdominal central adipose tissue is metabolically active and releases large amount of free fatty acids, which induce insulin resistance by competing glucose as fuel supply. And the other thing is that adipose tissue release a large number of hormones called adipokine, which include leptin, adiponectin, interleukin-6, and human necrotic factor alpha. And this hormone binds to specific receptors to influence sensitivity of insulin in other tissue. In that way, obesity is the major cause of insulin resistance. And the other important risk factor for insulin resistance is literature describe that certain ethnic groups, for example, South Asian and indigenous peoples of America and Australasia, may have a very high prevalence of insulin resistance. It may be related to genetic and environmental factors associated with increased obesity in general. And following these things, another risk factor is physical inactivity or sedentary lifestyle. I think it is a modifiable risk factor because by doing regular physical exercise, we can overcome these factors. And the next thing is increasing age. Studies and data from the evidence support that there is reduced insulin sensitivity in increasing age. However, this may be due to consequence of increased adiposity and decreased limb muscle mass rather than a direct effect of aging. So the next thing is insulin resistance may be a part of metabolic syndrome. When a person can be diagnosed with metabolic syndrome if the person has central obesity, that is BMI more than 30 plus 2 of hypertension, blood pressure more than or equal 130/80, dyslipidemia, and fasting blood glucose more than or equal 5.6 millimole per liter, or type 2 diabetes mellitus. So, insulin resistance can be a part of metabolic syndrome. So, after we have looked into all the risks that are causing insulin resistance, the second important mechanism is beta cell dysfunction or defective insulin secretion. So let's have a look into risks that are causing it. The first one is genetic factor. Studies in first-degree relatives of type 2 diabetic parents and in twins have provided strong evidence for the genetic basis of beta cell dysfunction. And the second thing is burden of insulin resistance places a major stress on the pancreatic beta cells to augment their insulin secretion. As long as the beta cells are able to augment their secretion of insulin sufficiently to compensate the insulin resistance, glucose tolerance remains normal. However, over time, the beta cells begin to fail and leading to increased postprandial plasma glucose level, fasting blood glucose level, and finally leading to onset of overt diabetes. So, the another risk factor for beta cell dysfunction is aging, and the studies and evidence support the fact that aging is related with decline in beta cell function. And the last but not the least, lipotoxicity and glucotoxicity, that is elevated plasma free fatty acid level and chronically elevated plasma glucose level. Both these things impair insulin secretion. So why are these pathophysiological mechanisms important? Sure, it is very important. because when we start treatment, the treatment will be based upon reversal of pathogenic abnormalities. In that way, we can control blood glucose level and prevent microvascular and macrovascular complications. This is the end of the part 1 of pathophysiology of type 2 diabetes mellitus, and I will discuss evolution in pathogenesis in terms of triumvirate, ominous authors, and sweetening cysteine in next video. And thank you so much for your kind attention, and please like, subscribe, and follow my channel if you like my video, and see you again.